addressing falls in related but different ways. So it's now time for our panel. So I'd really like to invite our panellists up to the stage. So Charlotte, Kate, Laura, Danielle, Robyn and Andrea. Yep. Okay. Sometimes we have what's called a manual, but we've got the reverse of that today, with, which is nice to see. I might start off with the first set of questions and give each of you the opportunity to respond to that. It's great having such a big panel, but if we can keep them relatively brief, I think we'll be able to, really get the most out of this panel. So thinking about success in the work that you do, or in successful experiences you might have had with health professionals, can you tell us a bit about the factors associated with that success in falls prevention interventions? So you can draw on the research, organisational or personal experience. And we'll start with Danielle.
I'll keep it brief. I think collaboration is the key. We all think about it and we all talk about it, but we don't really do it. So we talk a lot about interdisciplinary teams, but there's a lot of friction still, like who does what, where do I start, when do I start? So one of the good experience we had is making it obvious that nobody feels comfortable working in interdisciplinary team was a key success in our group, where we need to put it on the table that we don't really like to work together. We don't work the same way, we don't use the same tools, and we don't speak the same language. So I think putting it on the table to start off with was a success story for us, because it's okay, we don't really like that, we're not comfortable, but we can do it, and we know it's important. But let's make it simple right now that we don't like that, nobody likes it, but let's work together because we need to. That was one good thing that we done.
Thanks, Danielle. That's fabulous.
Fab. Well, I'll come back to the ICA again with the three key features: that integrating with the local setting, tailoring to patients' needs and abilities, and involving patients and families. But I also was reflecting on the work we're doing and where it's having some success, and I think we're seeing an emphasis on goal setting with patients in terms of achieving, minimising falls risk, and then making it patient-centred to ensure that patients are active too. But I also think we can apply that principle with staff, setting goals as a team about how can we do this, in incremental steps to achieve optimal patient care. So goal setting, for both parties.
Thanks, Charlotte. And I might do the alternative question for Laura, because with your presentation, you found that it, in a way, wasn't successful in introducing the order set. And you've touched on some of those factors as potentially why. Can you expand on that a little bit?
Yeah, so I think within usually big health services, there are a lot of challenges with medical staff and getting education to staff that will have long-lasting effects. I think the challenges of a junior medical cohort are that they move around very frequently, and any education that you provide to one group of junior doctors might fly out the door in 3 months' time when they move to their next hospital or their next rotation. So really one of the challenges that we face is making sure that we're not overloading people when they rotate onto a new ward, but giving them access to the tools that are going to help them throughout that job, and hopefully that they can carry forward through the rest of their career as well. So certainly in our department, we have our own junior doctor education sessions for those rotating through geriatrics. which happen, regularly on a Friday, and we try and get lots of falls education in there. And similarly, we reach out to other areas in the hospital through general medicine education and things. But it is a real challenge for the medical staff.
And I might skip Kate for the moment and move to Robyn. We'll come back to you, Kate. Sorry.
Double time.
I'm going to have to structure the question. Robyn, like in your experience, what are some of the successful or the factors that make up a good encounter with a health professional? Like if you have a good experience, what do you think some of those factors are?
I like to be asked, not told, and health professionals are fabulous tellers. And particularly when it comes to something like polio, that's like the only disease that's a bit obscure and the health professionals don't know anything about. Because the truth is, most of you don't even know how to spell it, never mind what it is or what happens to us. So we tend to be sneaky with you and almost try to trick you sometimes. Make you look like a bit of a deal. Because you made a mistake and you say, well, that doesn't work, I can't do that. But I didn't know, for instance, just as an answer to your question, I've got 2 kids and I had my first child at 31. I didn't know I had no core strength until they made me lie on the floor at antenatal classes and say, sit up. And I lay on the ground in the antenatal class saying, I can't. Because I have to roll over a bunch of my pictures and get up. I was 31 years old. I'd seen a lot of health professionals and I didn't know I didn't have core strengths. So what you've got to do with anybody that's in hospital is really get to the guts of it all. After the niceties, if you're following football if you're Victorian, it's really, really important to get down to the nuts and bolts because you'll miss the boat. And I think I said earlier, people tell fibs. I don't know if you've noticed that as health professionals. Is there any other consumers in the room? Yeah. You tell fibs? Yeah. So, know that we do, and sometimes it's even pathological. We don't even know we're telling fibs. We're so used to telling fibs just to get out. So I think that's probably the only way I can answer the question, really. Having said that, you're all amazing. You do a great job, but you've got to work harder. No, that the big lot that's falls and causing, etc., is just a nightmare. Next.
Thanks, Robyn. We can go either way. Andrea, what are some of the factors you think are involved in successful falls prevention?
I think for me, keeping it on the agenda, it comes and goes, but we've really focused on it over years and years. It's our highest reported incident, and I think that's the same across a lot of health services. It causes a lot of injury and harm to people. But it does fall off the agenda. I know there's lots of competing priorities, but for me in our health service, it's one of our highest. And it's everybody's business, and that's what we're really focused on.
Thanks, Andrea. And over to you, Kate. You talked about, obviously involving family. And you also talked about the factors that contribute to, enabling that to happen. Can you give us any insights into where things might fall down or what factors, contribute to it not working out as well as it could be?
Yeah, interesting question. I think one of them is just simple logistics. Like we found with allied health staff that were wanting to engage with families that had said we'd like to be involved, that a lot of them don't carry mobile phones. So actually the logistics of trying to make that time work compared to, for example, the social workers who had a mobile phone and it was just easy, that was part of what they did. So there were some logistical factors. There are some kind of personal factors as well. Like we did come across in some of our interviews just a bit of a sense of feeling like sometimes family are telling me what to do and I know what to do, and that sort of sense of feeling a bit like, they're judging my work. I think more so with junior staff than more senior staff that perhaps are a little bit more comfortable to not know everything, and actually potentially over your years you've worked out that actually patients and families know a whole lot more than we do about a lot of things. So I think, maybe there's an education opportunity for junior clinicians around working with families as a part of the team, and just because they pick something out that's a problem doesn't mean it's like you're a bad clinician. It's actually a contribution to patient care. Yeah,
great answer. And another thing I was thinking about when you were talking is I suppose how to judge where maybe the family dynamic isn't actually a good one and there may be some issues, and how to upskill staff in without, if you're the physiotherapist and not the social worker, how to read the room, if you like, and understand where it might not be therapeutic. Do you have anything to say about that?
I think often in our work that we've done, that's pretty well understood, except for maybe we kind of go overboard sometimes with that's not going to be appropriate. So an example would be a husband who wanted to be part of his wife's therapy, like physio sessions, but he would interrupt a lot and things. And so the staff member saw that as a problem, and so let's make it at a time when he's not around, so we can get on with physio that we need to do. But talking about that with one of our consumer team, she was like, do you not see that is the person's life? When this person goes home, they're also going to be living with this husband. And so maybe you could engage and work out something together that could actually help them in their longer term, not change their dynamic, but work with it. Find out, what you can learn from how they function. So just very different perspectives on us in the hospital dealing with the here and now, and not probably because we're busy. And we have so much administration and meetings and things to be able to look at the person as an actual person living beyond our interaction.
Yeah, I think that's great response, and I suppose it's about also kind of being honest in communication between, the treating clinician and the patient, and, maybe it's not appropriate to have family there all the time. You might want to do something, and being able to be open and have that communication channel that is beneficial for all. I think you've really highlighted that.
Yeah, and certainly with our therapy work, it was always kind of with we could call quits on this at any time. Like if anyone in the party thought this is not working, we openly from the start said, let's be able to talk about that.
Beautiful. Would Hayley or Hannah like to ask the next question, or would you like me to continue?
The next.
Or alternatively, we can ask for some questions from the audience or from our online audience. We've got online audience question that Drew is going to read out.
Thank you. Can you hear me? Yeah. Okay. Firstly, don't shoot the messenger. Secondly, this has come up from Anonymous, so it may be controversial as a result. I'm not sure yet. So this is for Charlotte, and I think this is an age-old question. How do we balance risk of falls in acute hospitals with the risk of hospital-based harm? Because we won't let people get up and walk around on their own, as our falls risk assessment scores deem it too high risk. So they decondition, stay longer with risk of medication errors, delirium, infection, etc. Easy question.
Totally. But one, as a physio, I'm really passionate about. We don't want people not falling purely because they're not moving. And so we need to be weighing that up. I think coming back to that, what matters to the patient too from the very start. I think for our wards too that we've been working with, we've done a lot of brainstorming the drivers of fall. So why do people fall in hospital? And coming back to reminding people that people will fall, one of the drivers of falling is deconditioning. If people aren't moving around as much, they're going to lose strength very quickly, and then they're actually at increased risk of falling. So coming back to that point, I think can be really important in those early days of kind of addressing your barriers to implementing fall prevention interventions. I think it is hard because we've got to, that, as the question said, we've got to it's mandatory to report falls, but it's not mandatory to report patient activity, and so that's an ongoing tension. I think campaigning to try to promote increased activity and try to look at how we can increase reporting of patient activity levels so that can be seen side by side. Kathy Sherrington, my supervisor, often talks about how with road accidents we talk about accidents versus distance travelled. Well, in falls, could we be talking about falls per activity per laps of the ward walked? So, yeah, no silver bullet answers, but there's some thoughts.
Thank you, Charlotte. Did you have another one?
I've got a bunch of online questions, but do you want to...
We'll go for one from the audience. So I think there's one up the top, first of all.
Yeah, just for Kate again. Yeah, just for you, Kate, again. Just about the obviously got family input with your physio session. Just wondering, did you have any exclusion criteria to certain family members being engaged? Like obviously, you know, some patients, it's their elderly, frail husband that's visiting them. Like, did you have anything that was excluded?
Yeah, we did actually. So with the current study, it's like anyone, because there's different things people can do. But with the physio study, absolutely yes. Like even the patient, we needed them to be able to stand themselves. So we weren't referring, having patients that needed to assist, for example, to stand up, or even, I think even one assist, we were, they needed to be able to stand up. With families, yes, they needed to not have, an older person partner with back pain. They weren't part of that. But that was a conversation rather than because we don't have information about family members in our medical histories. So it's a conversation with them. Yeah.
And we have Wendy.
Thank you. My interest is in continence, and continence particularly on the wards at the moment, the projects we're doing here in Royal Melbourne. And so I'm interested to know whether you've tied your continence assessment and auditing to your falls processes.
Who would like to answer that?
I'd like to say if you are or are not, please do, because where the toilet is and how hard it is to get to is a big issue if you are remotely disabled.
And even if you understand your urgency, which is
Yep.
just you work late, because you can't wait.
Yeah, I don't mind jumping in first, but seeing out if anyone has other things to say. I think as geriatricians, I think that we try very hard to incorporate this in our routine assessments of patients, and certainly when we were constructing the falls order set, we did build in assessment of continence with bladder scans, bowel charts being, bladder scans automatically selected on our order set and bowel charts being included as something that people could add on. I think in terms of the rest of the hospital's interest and engagement in addressing continence, I think that's something that we could definitely work on, and maybe as geriatricians that's something that we need to take on in terms of an education role, and it could definitely be done better, but we certainly do try to address continence management.
I can, absolutely, we're in the programs I'm involved in across our hospitals, we're absolutely aiming to incorporate incontinence and toileting. The approach we're taking is sort of one focus at a time, and wards really over time identifying the drivers, and so for a lot of the wards it has been around toileting and incontinence, and so examples of some of the work some wards have done include one ward we've worked with, they've tested all their incontinence pads to work out which are the most comfortable to enable patients to remain active, because we had the big issue of, patients actually can't walk around in their incontinence pads and underwear. So that's one approach one ward's taken. Another is looking at, timing when patients are sitting out of bed for a meal, timing that with toileting processes too, so trying to formalise those toileting processes too. So definitely it's part of the package, but there's so many bits that are part of it, so working with wards on those goals, one goal at a time, has been our approach.
I might take the next question from our online audience.
I'll start loud and then...
sorry.
You're right.
Mike logistics, so I'll repeat the question if you want.
So this one's sort of about inpatient rehab versus community-based rehab and the evidence for that. So this person is wanting to know, is there evidence that inpatient rehab is better than community-based rehab for reducing falls? And the context is that there's often a lot of push from families for inpatient rehab rather than getting them home after a fall without serious injury, but this setting carries more risk in their mind given hospital-based harms. So who wants to have a crack at that one?
If you've truly had a nasty fall, you can't go straight into rehab. You're too sore. You won't cooperate. You actually do have to go home for a little minute and take a lot of Panadol, and a week or two with some sort of level of natural healing will get you to a stage where you can rehabilitate. Now, do you need some respite between hospital and the rehab? That's another argument for you cleverer people than me. But let me tell you, when you're pushed and you're sore, you don't cooperate.
you have another one, Drew?
Charlotte, do you want to?
Charlotte?
I was just going to say, in terms of the evidence, in terms of falls outcomes, there's stronger evidence for the impact of exercise and, you know, community-based exercise programs as a long-term fall prevention strategy than we have as exercise as a fall prevention strategy while someone's in hospital. But we're probably lacking some of that evidence around the impact of the exercise in hospital or in rehab then transitioning to community. But yeah.
Danielle, did you want to add something?
Well, I think the evidence, like the clear evidence, are not there comparing one to the other, and then you can't really erase what you've done in the hospital setting. So like you have to control for how long you were in the hospital, for what reason you were in the hospital, and then how you transition, like the length of stay at the hospital versus. So there's a lot of factors to control, and that's why it's hard to have this evidence. But I think it's about the perception, though. There's a perception that you're more cared about at one-on-one in the hospital setting versus in the clinical setting, or outside in the community. So I think like there's a strong perception that the longer you stay in the hospital, the better you are in care. And it could be related as well for like cost and access to like community rehab. So we don't have the evidence. The answer is, and it's hard to get because there's so many variables in different cases. I think it would be hard to do to actually prove that. Yeah.
Just one for Kate. This is a really interesting question. Have you looked at any family models of care in resi aged care where staffing can be a critical issue? And the context is they're interested if there are any concerns that very willing and motivated family members are filling gaps where the focus needs to be potentially on highlighting the staffing issues.
Yeah, interesting question. No is the short answer. While I was doing my PhD, I was doing a bit of clinical work in a residential aged care home, and at that time I was like, oh, we could do that here. Like there was some interest there, but it's not an area that I've done any work in. And it is interesting, I mean, broadly speaking, looking at family assisted therapy or physiotherapy across the world, there's some different models of it, and one is that people have the usual care and then you add family involvement on top. And then there's others where it's what we call task shifting, like say in low resource settings, sometimes it's been investigated as something that is instead, but usually because there isn't anything else, and then let's put family in. But it raises some really interesting questions around environments that we have that are low staffed, and you know, how does that impact, you know, family engagement? How does that impact conversations about staff? And it worries people, yeah.
And yeah, Terry, while the microphone's coming, also the burden on potential burden on family members that are having to step in and, you know, like take over. All things to consider. Terry.
A question about knowledge translation aspects of the evidence into practice and the common step of local contextualisation. And I think, you know, Charlotte, you brought up the issue of with education in your talk, and you know, it's not just a brochure, it's not just this. Where do we need to draw the line between fidelity to what was actually used in the trial and keeping those key ingredients versus chopping away until, oh, hold on, we've got a brochure, but that's locally contextualised, and that's a solution we're going to use locally. Where would you draw that sort of line in your experience between the evidence base and what actually gets used in practice?
We're fighting here. I think like there's framework that exists to go from like an evidence-based program to be adapted, so it's still like, and you still test fidelity on the way. The problem I think like is that we take something that exists and we kind of sit around the table and let's make it local. And then we don't know like how much the adaptation was actually like still like fidel to the intervention. But there's actually like framework, and we don't use a lot of frameworks to do that. We just like go as we think. But there's plans or a roadmap for you to do the adaptation, and you can track what you've done. And then at the end, you still test fidelity on the way. And I think that's what we're not doing. As you said, like we just like take it, adapt it, and then it's the same thing but adapted. But you lost some elements. And when you do it on the fly, you might remove some key elements of the original, and then you don't know. Because when we do an RCT, there's always many elements that you don't know which one was the driver. and you might locally remove that driver, and then suddenly the intervention is not valid. So I'd say, like, as long as you follow, as you track what you change, and you still test at the end, that's fine then. And we don't do that extra step. We just say, it worked here, we modify. It's an adapted version, so it works, but we don't know. So use a framework, I think, is the key.
Yeah, and I mean, I thought of what in your presentation, Danielle, you said, like, exercise, any amount of exercise is good. We want people to do exercise, so great that you're doing something, and sort of there can be that thought in falls prevention too in hospitals. We've got to be doing something, so we're doing something, so is that good? But I think what we really need to ensure, what is also embedded, is local data, looking at your local data to know, okay, well, if we're adapting it, are we getting change from that adaptation? And so really empowering staff to understand their local data to see how that can inform whether the changes they're making are actually having a positive impact on falls. And it's not always just the number, it's about maybe them knowing, well, we did have more falls here, but why did we have that? And so that they're able to really see if they have locally adapted it to their context, is it still having an impact?
Any questions from the audience? So we've got one up the back and then one in the middle. Extra steps for Sarah.
That's right.
I just had a question about specifically the talk that was about speaking to patients about maybe being a bit overzealous with falls prevention in terms of, are they trying to go to the bathroom by themselves? Are you allowed to let them go? It's kind of a two-part question. Number one is, where do you draw the line between giving them the autonomy and then actually preventing the falls? In terms of, can, you know, if I'm a nurse and if I asked the majority of my patients, do you want to go to the bathroom by yourself? They would say yes, but I can't let them all go by themselves, or else there'd be falls all over the place. And also in terms of, maybe this is probably more specific to aged care, but it is across the board. A patient themselves might want to go to the toilet by themselves, and you might feel comfortable, or decide if it's comfortable to let them do it. You let them do it, they fall, and their son or daughter comes in and says, why the hell did you let them go to the toilet by themselves? That's why they're in here, you're supposed to be looking after them. I'm just wondering, how you, is your tool, or is it more kind of individual, or how do you find that balance?
I think in the aged care context, we have something called dignity of risk, where we're learning about individuals' preferences and then trying to help them manage their choice. And we have dignity of risk, where we talk to them about what they want to do, and we get family or the resident to sign a form. But even, you know, in hospitals, people want to go to the toilet and they don't want to wait, they will go. So, you know, we've got to support that.
And there was a question here. And people will go to the toilet if they need to.
Yeah.
First of all, thank you for all the presenters. That was great. Maybe I have to say, I'm a health consumer advisor, and hearing a lot about these falls. This is the interesting and very important issue. It's a complex, we need a comprehensive solution. I'm just wondering, what do you think of using the AI to assist the patient to preventing the fall when you are coming or going towards the research? Have you ever thought of that? Something like a very simple, looking for the device the patient can carry and assisting the patient. Have you ever? Because from my perspective, you have to look at the outside the box, rather than just recycling the information and updating the information, which I got the message to all of you. We are not reaching the targeted outcomes. Is it the time to look at outside the box?
No. Who wants to comment? Robyn, do you want to take that one first?
Well, you're asking me a very personal, emphatic answered kind of question. Do I want to go to the toilet with anybody? No, including a machine. No. If I, however, in my home, so I can stay at home, there's a machine that says, Robyn, you haven't been to the toilet and done a wee for 2 hours, and reminded me to go, well and good. But do I want it to follow me in there and tell me to take my pants down? And I'm telling you literally, because I've just been at a conference about this, at Jeff's shed, and this machine tells you to take your trousers down, take your pants down. No, you haven't taken your pants down. You can't sit down yet, Robyn. It is the level of detail of how I go to the toilet was mind-boggling. And I think if I was that level of confused when this machine's telling me that no, I can't sit yet, or not, may in fact not be. So I don't think the technology's there yet. Will it ever be there? Yes. But golly, the cost of it will have to be extra. I don't know. They told me this machine that was telling me not to take the pants down yet, etc., was $180,000. Times however many old people in this country, let's fix a few potholes and things Thursday.
Thanks, Robyn. Kate, would you like to comment?
Yeah, I would just say I think there are some people out there doing, even locally in Melbourne, doing some work around looking at hospital records and using AI sort of algorithms to try and identify, different things. My personal little hesitation is, I think, and I've worked clinically in hospitals for a long time, and I really respect that my teammates that I've worked with, and I think, broadly speaking, we've got a great health system in Australia, right? We're very lucky to have what we have. But particularly when it comes to care for older people, there's a lot of gaps, and I think an AI algorithm is only ever as good as the data that's put into it. So if we have a system that's quite ageist sometimes, makes assumptions about people, uses nasty words to say they can't cope anymore with life, and then I just have a little bit of hesitation. I think we need to really carefully examine what we're doing, and not. I worry sometimes that some of these technological things look like really exciting things. We'll pay lots of money for them, but we might not pay lots of money for actually having staff on the ward that are humans that might even be able to help. So I wouldn't throw it out. And I think over time, we're obviously heading in these kinds of directions. There are some good people doing some interesting work, but yeah, I feel a little bit worried about the data we'd be putting into it.
Anyone else like to comment on that?
My comment is just very closely linked in that if, I haven't been looking at AI yet, but if I were to, it would be where it can be used in processes that take staff away from face-to-face time with their patients, and where it can be used to improve efficiencies there, so that we can still be our skilled expert staff that are there with our patients as much as possible.
I was just surprised how much, I was thinking about this earlier, we have not talked about technology at all, which is a bit similar, different than back home, where 4 out of 5 presentations about using technology to help enhance the care for seniors, so we reduce falls. And it must be related to funding, maybe of searching those answers for technology related stuff. But the acceptance of the technology is the issue back home. It's not about how good they are. You have monitors that will tell your family members that you fell and they show up and you haven't fallen, or you did fall. The ability is pretty good, but the acceptance, and maybe the next generation where we were born with technology and we actually have devices, might be better suited to apply the findings that we had. There's studies on the smart can and the smart walker and all those smart things, which are aligned better with the next generation of seniors. So I think the findings in AI being part of that, I think the findings that we have right now is not matching the population we work with. But I think there's a lot of advancement that might actually reduce the risk of falls in the hospital and homes that are not quite accepted yet by the population we're targeting. But that might actually be well in advance in 10 years from now, and you kind of need the right timing, I think.
Yeah, I think so. And I think like many other interventions, it's around the implementation of technology. And as the chair's prerogative, I'll just put in a little plug for a framework that we developed at NARI at the National Ageing Research Institute around the implementation of technology into home-based aged care, which covers a range of factors and the facilitators and barriers, and it's freely available to download. Okay, any other questions? We've got Terry down here with an easily accessible mic.
Question for Andrea. This is an aged care focused one. The comment that the falls data goes back to the star rating of aged care facilities, and your comment about the dignity of risk. I feel like we've got the wrong measurement feedback loop here as a country. shouldn't we be discarding falls amongst residents who have had a dignity of risk conversation and said, I want to be able to take that risk in my life when I'm living here, and okay, if you fall, that's not a marker of care quality against the facility itself.
Yeah.
So that metric, that feedback loop in that metric.
Yeah, I mean, it's a perverse disincentive, you know, could even affect falls reporting. I don't think it does in most facilities because aged care are good at reporting falls. But it's interesting, and it definitely should exclude people the dignity of risk and all the, you know, changes to the Aged Care Act, and you have to promote autonomy and choice. But if you do and they fall, you're going to get 3 stars, and that's what consumers choose their facility on. So yeah.
I think that's potentially something that the Falls Coalition that we could potentially look at as a group and advocate on, because I think that's a very perverse incentive for care.
Yes, definitely. Sue, we've got a question. Maybe Terry, you can pass the microphone up. One here and then one up the back. Yep.
Thank you. I think this one's to start with you, Kate. Your comment where when you're sick you belong to the hospital, and now that hospital is now no longer just the built environment but a home-based setting, and yet the staff are adverse to allowing, in many cases, family to be involved in the care, but at some point there's a decision where now this person is going to transfer to home, but we really want the family to be involved now and forever, and they have been before. And so we're comfortable with transferring not only the patient into the home-based setting, but transferring the risk. Can you comment about that?
Yeah, that's such an interesting comment, and something I grappled with when I was doing the intervention part with the family assisted. You know, when you've got, I guess as a clinician that was passionate about this area, I could kind of go, this feels really scary and risky, but this is, for this person, they're going to sit and do nothing, he wants to move, that kind of thing. I think our carer training that we do always seems to come at the end, and sometimes it's sort of like, why couldn't we even just something that we always do, but why don't we do it early so that someone could actually train under guidance, you know, for that period. I think the thing is, we're not having everyone getting sued for stuff very much at all, right? Like, but we're all really worried about it, and I think that I don't personally know where to start with that even, except for maybe talking with some of our governance people. I've got an amazing consumer on our team that might have some expertise in that area to actually unpick why are we all so scared of, you know, letting people do stuff, because we all know, like you're saying, we all know that tomorrow they'll be home with their family and, you know, off they go and they do it. But like you say, we're transferring that risk. I think risk is a big problem for us that we haven't really addressed.
Thank you. And there was a question, up the back to my left.
Thank you. My name is Chris, I'm from Bowel Health. Something, and I think I mentioned a few times today, this product of course, is everyone's responsibility. The issue with that kind of slogan is that often then falls to no one. So I'm wondering in particular around education and meaningful education. I think that the pamphlet is a lead example of it's everyone's responsibility. We just kind of give out the pamphlet and then it's done. For education is the time to get rid of the it's everyone's responsibility and make it someone's responsibility for that meaningful education.
Who'd like to answer that one?
I guess when I've talked to some of the staff, and this is particularly within aged care, they do know what prevents falls. So I think the education, people have been educated, but perhaps it's more on making sure that the system in place to support it, that they've got the staff that can implement it, the interventions that's needed. What was the question?
Should it be one person responsible? If it's everyone's business, then I'm paraphrasing here, then it's no one's business. So should we make
I don't think that would work either. Nobody's got the time to be one person, and nobody's there 24 hours a day. We've got different shifts. It has to be everybody's responsibility. We found that some of the support services, the cleaners that see the people every day, they're the ones that are picking up. There's some kind of slight change in there from yesterday. And what does that relate to? But I think it has to be everybody's responsibility.
So is it how we operationalise that maybe is the key? Like I think it's this is the how question has come up quite a lot. Like how do we do that? I don't have the answer.
I mean, I don't have the answer either, but I think, a start is by going back to that individual context and saying, well, in our service, on our ward, is it not happening because everyone thinks it's their responsibility and no one's actually doing anything? And everyone can have responsibility, but then individuals can have clear individual roles then within that responsibility, and I think that's the bit that's sometimes missed in that everyone's responsible, but everyone has individual roles, and what role is everyone's, and does for our ward, is it going to work better if we have someone that clearly takes on doing that goal setting with the patient around reducing their falls risk, or are there a couple of teams that have, disciplines that have that clear role within that overall responsibility?
We have tried to do that in one project that we were doing in conjunction with Austin Health and Royal Melbourne Hospital, but particularly at Austin Health, where it was that role clarity to say, like, if you're a cleaner walking past a room and you see someone get up, like, you should go and press the buzzer and let the nurse know. Not that you have to walk with the patient, but that's your role as a cleaner, your role as the physio is to do X, Y, and Z. So maybe that's a way to approach it with the role clarity and definite actions that are to be taken rather than just, the slogan, which is, I think, your point.
And we had an example lately where they took kinesiology people to reduce the burden of mobility in hospitals. And since we included kinesiologists in the health setting, we saw a reduction in the mobility. So a bit like what you're saying, we identify people now that will take care of mobility. So everybody else in the past that were taking care of mobility don't have to worry about it because the kin will take care of it. So it backfired on us. So now it's well, what do we do with these people now if they're not helpful? So that's a different question. But it is to your point. If you clearly identify somebody that is taking care of it, then no one else has to worry about it now because we have these people. So we need to be careful, and I think a scientist comes back to you need to test which setting works better. But with clear data, what's better. But it's not obvious that if you give the role to somebody, that now suddenly it gets better. It didn't seem to be that case.
I love that because it shows us sometimes more from our failures than from our successes. I think I'm just keeping an eye on the time. We've got time for one more question from the audience, and then I'll pose a last question to our panel. Robyn, do you want to say something?
I just want to answer the last question. How many of you are an adult before 1972?
Oh, no.
Okay. Well, let me tell you what it was like to drive a car before 1972 without a seatbelt and being about .99. And wondering why Austin Health was busting at the seams with over 1,000 quadriplegics a year, etc. Overnight, we put a seatbelt on and stopped drinking. And now today, I've got teenage grandchildren, they are seriously, one of their Christmas presents on their 18th birthday, one of their birthday is a breathalyzer. So they wouldn't dream of driving, etc. We are talking about societal change here. I don't believe this is just your job, and somebody's already stated this is everybody's job. If we're going to stop falling over and dying because of it, and we don't want that to continue, each and every one of us has got to fill a pothole, has got to put a decent stair rail down a set of stairs, and so on and so forth. We've got to pick this up as a nationwide issue, like I said earlier, a slip, slop and slap notion. This is no joke. It hurts. And it's hurting our children because they're paying the taxes for me to be in hospital, etc., etc. So it's a multi-generational impact and it needs to change. Go seatbelts. Look up the legislation, look at the societal change. It was incredulous.
Thank you, Robyn. That actually might lead us, sorry for the questions that haven't been answered, But if you do have questions, you can send them through later and we can pass them on to any member of the presenters today. But my last question to each of the panel was really a blue sky thing, like if you could do one thing, if you could wish for one thing to make a change in falls prevention, broadly, what would that be? So Robyn has advocated for a national campaign like Slip, Slop, Slap, but I think, what did you call it, Robyn? Stop, Slip, Stat.
Or stop, slip,
Something like
stat,
that.
or stop, slip, slap.
Yeah.
I've been sending all the S words to Francis. Any more S words other than the obvious one? Please don't send them to Francis.
Andrea.
I think stuffing's key, but I've had to put stuffing.
Staffing, okay, beautiful. We need more staffing.
I need families to talk. They don't talk about any of this, and so like advanced care planning and all that. Talk to your families, everybody.
Good point. Kate?
I'd say look at our systems. They're so complicated. We've got so many bits, so many administrative things, so many ideas, so many processes. Could we simplify some of that and get back to just helping people?
We'll take that one on notice. Laura.
I guess my thoughts are similar to Robyn, and I think that, you know, there are so many problems out there in the health world that attract a lot of sympathy, empathy, attention, and they're easy to get people excited about, like oncology, and, you know, they do fundraising very, very well and attention very well. And I think finding ways to engage the community in discussions around falls is probably pretty key, because it's such a big problem, and comparative to other similar you know, financially impactful issues, it's not anywhere near as much talked about.
Thank you, Laura. Charlotte?
Oh, I'll touch on built environment. You know, it does play a big role across settings, and I think we're having huge redevelopments of our hospitals in New South Wales, and there's been a lot of consumer consultation, but not diverse consumer consultation necessarily. So the new maternity wards have the same layout as our new aged health wards, which isn't necessarily, doesn't need to be, you know, there are different needs. And so really coming back to prioritising, thinking about what matters to the individuals that we're providing that healthcare to.
And Danielle,
big question, last one.
Yeah.
I think we think a lot about how things are complex, and we can't really do things because things are complex. But from all the literature that I can read on any falls prevention or anything, like if people would walk 2,000 extra steps today at all ages, and staff and family members and patient and anybody that is sitting here, we would have a better world and a bluer sky.
Thank you. Please thank the panel with me. So I'd just like to wrap up this morning's session. It's been fantastic. I want to thank all the presenters who did a wonderful job, and it was great to have a diversity of presentations, but I do feel like there was a common message of, like, maybe we know what to do, but it's how we go about it, how we implement it, that seems to be a theme. So it was great to hear that diversity, but also kind of the commonalities. I'd like to thank all the attendees, both in the room and online. It's a fantastic turnout and testament, I guess, to the interest and passion of all of you in this particularly important topic. And I'd like to thank in particular the organisers, so the MAC team, the people who are running around today, but particularly to Mel and Nick, who've done the grunt work to get this underway, this session underway. That's been fantastic. There is the QR code up. We're really interested in your feedback so that we can design future forums that meet your needs. And the last thing to say is that for those of you who are joining the Community of Practice meeting, we will be meeting just near the registration desk to walk over to the North Melbourne venue. So the people who know that they're doing that will have already signed up for it. And I think with that, we will now... Oh, sorry, I forgot to thank Hannah and Hayley for co-hosting. That's been fantastic. And with that, we will wrap up, and we look forward to seeing you at next year's symposium and other events that we put on. Thank you.